It is now my pleasure to introduce the second speaker, Dr. Albert Mwango from Zambia, who is going to focus on aspects of sustainability of HIV and antiretroviral programs. He is a medical doctor and a public health specialist and an HIV clinician for many years. He is currently the Deputy Chief of Party at the Catholic Relief Services Program, an implementing partner in Zambia. He has formerly been the coordinator of Zambia's national ART program and has served on HIV guideline committees in that country. He is also published in the field of HIV, and we look forward to your talk. Dr. Mwango, please take the center stage.
A very good day, everybody, and welcome to this presentation. I'll be looking at evolving HIV clinical pathways and specifically how they relate to sustainability of HIV treatment in resource-limited settings. We'll start with the definition of sustainability, and this is the ability to be maintained at a certain rate or level of any outcome or desired result. In HIV programming, we'll focus on clinical pathways because these are the different strategies that get us to certain outcomes, better or even more improved outcomes. And the outcomes that we focus on in HIV programming are those of biological and immunological responses of our patients. And also we look at avoidance or reduction of depletion of resources. And thirdly, improved clinical guidance, which largely focuses on quality assurance and safeguarding high standards of service provision. Fourthly, sustainability is brought about when we have set goals and targets, and we've had global initiatives that have helped us to do this. Initially in the early 2000s, which I'll talk about in detail later on, we had the 3x5 initiative. Then we had the treatment 2.0, test and treat. And currently we are going through the epidemic control strategies and goals for 1990, or in some places 95. And there have also been other global initiatives that have helped HIV responses, such as the Sustainable Development Goals. Sustainability it can also be viewed in certain preferred outcomes. We can focus on better survival for our patients, longer life expectancy, and also having well-managed chronic conditions. And HIV has now become a very well-managed chronic condition in most parts of the world and for most of our patients. Resource-limited settings, sustainability focus in the early 2000 to 2010 were largely based on improving access to treatment. The WHO 3x5 initiative was launched to help countries improve access to treatment, and the aim was to have 3 million people living with HIV to be on ART by the year 2005. It also brought in other focus, such as human resource capacity building, and this gave birth to issues like task shifting, which have really gone a long way to sustaining our services and the delivery of efficacious treatment. We also, during this period, focused on providing efficacious regimens which were new and not previously accessible to many people. One of the byproducts of this was to introduce tenofovir, TDF, as a first-line drug, which was used in patients who are just starting treatment. This had largely been reserved for second line. And this helped us really achieve avoidance of resistance by introducing TDF in the first line. Other issues of focus were improving convenience and accessibility through fixed dose combinations, which were now at that time more readily available as they are today, and also generics. In 2010 to 2015, the drive went on to scale up universal access and maximize preventive benefits from using ART. And at this point, countries started prioritizing optimization of ART regimens. They looked at rational and efficient use of resources, and also provision of point-of-care diagnostics and monitoring tools. This was an area of HIV service delivery which was largely neglected. We saw CD4 and viral load testing services being expanded, early infant diagnosis on PCR platforms through DBS being expanded, and also diagnostics for TB, such as Gene Expert. In 2015 to 2019, the priority changed to going into the first stage of achieving epidemic control. And through this process, there was emphasis on diagnosis and treatment of HIV infection, control and halting HIV transmission, and at the same time, sustaining viral suppression in a critical number of HIV-infected individuals. And we're looking at this largely to have 90% of those on ART being virally suppressed. The benefits of this is reduced numbers of deaths and also a reduction in new HIV infections. And effectively, achieving that is epidemic control. We're not forgetting as well the need to have zero tolerance for stigma and discrimination as we are providing all these services to people infected with HIV. This year, 2020, has largely seen the effects of the COVID-19 pandemic, and the priority has been to safeguard the HIV programming gains. This has been done through universal prevention activities such as masking up, social distancing, regular hand washing, which is a very important strategy and procedure for all diseases, and also self-isolation, which we have seen to a very large extent on the social scene to avoid coronavirus transmission. For the HIV world, I think the most important strategy has been the multi-month dispensation, which has really supported patients to continue on treatment when they cannot have contact with their health facilities. So the multi-month dispensation is a model of differentiated service delivery, which has really protected our patients from coming into contact with coronavirus. So over the years, there's been an evolution of guidelines, and this has impacted on patient care in various ways. And some of the notable challenges which I'll mention, although this is not a conclusive listing, has been to improve access to diagnostics. Guidelines have made us want to have more CD4 counts done, more viral loads done, and also monitoring of treatment, even to the point of using point of care. The human resource capacity has continued to improve the numbers and skills. The costs have also reduced. The early costs of TDF were quite high, but right now it is much more accessible and affordable for most countries to use this very important drug in treatment. And soon we'll be moving to TAF, a very similar drug to TDF. There's been availability of generic formulations, and also we've had more potent and efficacious drugs being introduced on the scene, such as dolutegravir versus the NNRTIs that we have used in the past. The drugs are much more convenient because they come in fixed dose regimens or combinations, and they can be dispensed on a multi-month basis. During this period, we've also focused on improving commodity security and management of these commodities, as we have been phasing in and phasing out products. Currently, there are some forward-looking changes which we should embrace and should help us sustain our goals, our outcomes that we have achieved so far. We have DTG, a very potent and efficacious drug that is now available for children and adults. can be used in first line and in certain situations for second line. It can also be used for patients who are co-infected with TB. Multi-month dispensation, very important in this COVID-19 era to keep our patients on treatment even as we are reducing contact with the health system. 2 drug regimens are coming on the scene. Obviously, this will mean there will be cost effectiveness. It will be less expensive to have efficacious regimens, and also a reduction in side effects and toxicities. We also have long-acting regimens that are also coming on the scene. These are all under testing, but they'll be given on a 4-weekly basis, which will also reduce the need for people to access health facilities. So in conclusion, guideline changes have produced sustainable results, and we'll continue doing this if we embrace the strategies that harmonize approaches, especially for children and adults, integrate service delivery for various conditions, and simplify treatment. And above all this, optimize the drugs and protocols that we are using so that we have a sustainable HIV program. Thank you so much for your attention.